Great to see you, right? We've been doing so many things remotely. It's actually so nice to see some faces and some bodies. So welcome to Patient X, which is sponsored by the Pre-Health Advising Office. I want to give a special shout out to Hugh Grant in our office, who does a lot of the organizing around this event. I also want to thank our peer mentors who help as well. You want to say hello? There we go. Our peer mentors are the eyes and ears of our office around campus and great sources of information and resources. We decided to do Patient X a little bit differently this year. Has anybody been at this event before? Good. It's also nice to know who our audience is. So who are first year students? Second year students? Any third years? Fourth years? Any alums? So we have a nice variety of folks in the audience. That's great. Our primary sort of focus of a session like this is to give you some insights into something we talk a lot about, that healthcare is a team sport. Has anybody ever heard that before? Good, good. It takes a lot of people, it takes a village to take care of patients. And it's not all about being the doctor. There are lots of other people involved. I will say that this year we have a special focus on an area that is touching all of our lives, and that's this whole area of climate change and its impact on health. I'm going to let our panelists introduce themselves to you, and I'm going to start off by turning it over to Dr. Becca Phillipsborn, who is really somebody that I've known for so long. I met her when she was a medical student here at Emory. I saw her during her residency here in the Department of Pediatrics, and now work with her not only as a fellow faculty member in the Department of Pediatrics, but just a few months ago, she's joined me as an associate director of the pediatric clerkship. So helping to shape the sort of clerkship experience, the clinical experience of all of our medical students that will rotate through the Department of Pediatrics. In addition to all of that, Becca is really, I will say this proudly, becoming, if not already, an expert in the area of not only understanding the impact of climate change on the health of the children we take care of, who will become adults, but she is also doing an incredible amount of work in embedding this kind of information into medical curricula. So I say that because those of you going off to do all sorts of professional work, educational work, will need to know this, because time is really of the essence, and this is truly one of the urgent challenges of your generation, and unfortunately not as urgently recognized by my generation. So I turn it over to Becca, who will get us started, and we will allow the panel to introduce themselves. Thank you for being here.
Thank you. Thank you, friends. Thanks for inviting me and all of us. I am really happy to be here tonight talking to you all. I don't know that I have much to add after that introduction, but I'll tell you about what I do on a day-to-day basis. I do general pediatrics, so take care of children at their well visits when they get sick. I'm down at our Hughes Spalding Primary Care Center, which is on Emory's Grady campus downtown. We see children from the time they're born all the way up until they're 21 years old. And my scholarly work, as Dr. Batitsky mentioned, focuses on climate change and how climate change affects child health and actually patterns of child mortality in the US and around the globe. As a part of that, I sit on the executive committee for the American Academy of Pediatrics Council on Environmental Health and Climate Change and lead our education efforts. And then I'm a member of the working group of something called the Lancet Countdown on Climate and Health. You may have seen just this past week was this year's Lancet launch that we call it. Emory's the sponsor now for the third year in a row. The launch uses data from Rollins School of Public Health, and it's an effort to track where we are as a healthcare sector and where we need to be addressing this crisis. It's been called both the greatest health challenge of our time, but also the greatest health opportunity of our time. And with that, I'll turn it over to my colleague, Rachel Usher.
Hey everyone, good to see all of you. My name is Rachel Usher, and I am a program manager in the School of Public Health for two different initiatives. One of them is the Georgia Climate Project. So Georgia Climate Project is a group of higher ed institutions in the state of Georgia looking to address what a changing climate means for Georgia and what we can do about it. And the other initiative that I'm a part of is with the Emory Climate and Health Research Incubator that's really looking to make collaborations across so many experts on this campus to advance research on climate and health. Beyond that, my position sits in the School of Public Health. I am a 2020 Master's in Public Health graduate in epidemiology. So I know, I hope today and what I can contribute to this conversation can help all of y'all realize, regardless of what sector of the healthcare field you go into, public health plays a major impact in thinking sort of holistically how to think about patient healthcare and outcomes, and climate and health is really preeminent issue within public health today. So I hope to hear from y'all and get some good questions, but thanks again for the invitation. It's a pleasure to be here.
I'm Jeff Toy. I am a fellow in the Turner Environmental Law Clinic at the Law School at Emory. So I am the least healthcare oriented of the panelists up here. My role is kind of to help supervise and teach law students in the Turner Clinic, which operates as a public interest environmental law firm housed within the law school. I went to law school at Emory, graduated back in 2016, and I've been fortunate enough to be able to come back and rejoin the community. And I'm excited to talk tonight a little bit about how environmental law is related to healthcare and how the efforts of doctors and scientists inform some of what we do in the environmental law space.
Great. I'm David Grinke. I'm a fellow, a different type of a fellow in pediatric emergency medicine. So that means I finished my residency in pediatrics and then decided to do a fellowship in pediatric emergency medicine. You know, and I was thinking about this in 2003, I was actually sitting in your shoes. And then I actually took a bit of a different route. I took off 5 years after college and then ended up doing a post-bac. So I stopped the pre-med stuff undergrad. And I just mentioned that because there's many ways to skin a cat, I think. And I think the reason I came back to medicine is because I felt it was a career, and I think medicine broadly, health sciences, these are careers where you can really mold it to your own interests and fold in interests that might not seem directly related, but you can make them related. And I think this event tonight is a perfect example of that. So I'm happy to be here and looking forward to a discussion. I'll be talking more about the kind of how to think about these cases when you're seeing them for the first time clinically.
Thank you. Becca, if you want to go ahead and get us started with the case.
Yeah, we'll do that. And I apologize, I'm going to be reading, so I'll be kind of sideways as we get started. But our first case for patient X, you all, in just a couple of years, are in the emergency room at Grady Hospital in downtown Atlanta. Patient X is a 25-year-old construction worker who presents to the emergency room with arm pain after falling a short distance off of low scaffolding at the construction site where he works. He reports that he's previously healthy, no known problems. He fell about 4 feet and landed on his left arm, and his arm hurts. So we're going to kick it off. Probably. Let me try again. I'm sure whatever's happening is totally meant. There we go. All right. Well, I don't know. Do you know, did you end up doing that, Hugh, or did I press a different button? Yeah, perfect. Okay. Let's see if I can keep actually. So what would your next step be in the emergency room?
Yeah, so, you know, in the emergency room, we see probably, I don't know the exact statistics, but the vast majority of patients that come to the hospital get funneled through the emergency department. So we see, if you can think about it, we've seen it, or we will very shortly. And so, you know, with this particular patient, you know, with any patient that walks in, you know, our first concerns are there any life-threatening situations that we need to address immediately. And so for this patient, we know that this patient is breathing, is awake, is interactive to some degree. So we can be reassured in at least in the immediate sense. And then, so we know that the patient has some arm pain, and his heart's beating a little bit fast, and he looks a little warm. So actually, you might think, well, we need to think about the arm pain and understand what's going on there, but that's actually not one of the first things we think about. We actually want to think about more of the systemic things going on. So why is he beating? Why is his heart beating so fast? Why is he drenched in sweat? Why does he seem uncomfortable? And is there something that might have led him to hurt his arm? Some other reason that we need to discover and treat.
Perfect. And so you may end up asking him some more questions. And over time, that heart rate comes back down. He drinks some water. Things seem okay. You get some basic lab work. You're waiting on that, and you go ahead and get an X-ray. When you, sorry, I should have actually, I know you kind of referred to this, but he tells his story with an interpreter, which is critical. When you have a patient who doesn't speak English, we always want to make sure we have an interpreter present. And there's no other external signs of injury when you ask for his exam, except for this point tenderness over his left radius. So at that point, you feel pretty reassured, ready to get the X-ray in labs. Yeah, so we get this X-ray. X-rays don't always come with a nice blue arrow, but tell us what you see.
Yeah, so basically, where the blue arrow is, you can see a sign of what's probably a small fracture or break in the bone. And Dr. Phillips-Bourne, makes a really important point about the interpreter usage. So it's actually required by law, and this is a relatively new phenomenon. I mean, new in the past, I think 10 or 15 years or so, that it is required to use an interpreter, medical interpreter for patients that don't speak English as a first language and don't feel comfortable conversing in English. And we've made leaps and bounds progress in that respect. So that's really important. And it's not okay to use a family member or somebody from your department who might speak that language unless they're an interpreter, a medical interpreter who's certified. And sometimes there are situations where you can't get the language and you do need to use people, but you try to get an official interpreter. So yeah, so in regards to, this X-ray, does show signs of a fracture. So, but nothing, so we'd want to examine the hand and make sure that, we have good pulses, make sure that we have good blood flow to the rest of the hand, that the fracture is not, didn't hurt any of the blood vessels or the nerves. And so we would do an exam to make sure that those things are still okay. And we get some labs as well for this patient because of his presentation of he assumingly fell, what caused him to fall, why was he so tachycardic, why was his heart beating fast, why was he sweating. We'd get the rest of his vital signs too. We'd see if he is overheated actually, or if he does have a fever. If he does have a fever, is it from something, was he outside too long in the heat, working? Was he not hydrating enough, drinking enough water? Or is there something else going on? Does he have an infection that caused him to feel weak and fall? So there's a lot of different possibilities here. And we have to keep a really wide open mind in the emergency department because we don't know. And even when we do get a history from the patient or from the EMS or family members, et cetera, we still have to keep a very wide open mind and not to get tunnel vision because we could get into a hole that isn't relevant to our patient and it prevents us from seeing the bigger picture.
Perfect. And so his X-rays come back showing that non-displaced fracture of his, actually it says left radius. We also mix up our right and left sometimes. I changed that. And his vital signs come back to normal. He's not hyperthermic. He doesn't have pressure. His lab work does come back though, and you notice a surprising elevation of his creatinine without any other abnormalities on his blood work. So what is a creatinine? Why might it be elevated? What do you do with that for someone who came in with a broken arm?
Yeah, so that's a great question. So the creatinine is a test that we do. It's a proxy to kind of estimate the function of the kidneys. I mean, it's actually a muscle breakdown product. Is that correct? And basically the level of the creatinine, if it's too high in the body, then that means that for some reason, the kidneys are not clearing it quick enough, or there's too much of it. There's more of it in the body than there's supposed to be, which could be a sign of muscle breakdown. And you can get muscle breakdown from injury, from trauma, from a virus. You know, heating, like overheating, can cause muscle breakdown. So those are all things to think about. Or you can have a problem with the kidneys. Maybe this person has a kidney disease that is now manifesting itself potentially for the first time. And that's the reason that the creatinine is elevated. It's not being cleared quick enough by the kidney. So these are all sort of things we start thinking about.
Maybe you might tell this guy to follow up with his primary care doctor as the next step.
Certainly. And before you do that, you want to make sure that he's stable enough to go home. You know, or does he need to be admitted to the hospital for fluid management, for a little bit of better understanding of why this happened, what happened. Probably at some point call our nephrology friends to help us out to try to discover what's going on there.
You know, I'd like to jump in for a second. This should be less about medicine and more about the team effort and all that goes into healthcare. Who's keeping track of how many individuals have been involved with this patient's care? Any estimates? Well, who would you say?
The interpreter, the clinician,
Mhm.
and the body fellow, and the nurses, the techs, were all taking care of.
Sure. There's probably a phlebotomist. There was probably a medical technician. My sense is there might be a whole host of people that would be helping to take care of this person. So kind of keep that in mind too. And certainly I'd like our lawyer to weigh in on maybe giving some insight on this concept of requiring that a patient have an interpreter for their care. Have you thought much about that?
I mean, that's a fairly recent requirement, but it's a great idea. It's something that we don't see enough of in other fields. Interpreters are not always required in every avenue where they should be, but fortunately they are required in the healthcare.
And if anyone is even considering being bilingual, do it, because and even being bilingual, you still have to be certified as a medical interpreter, but it's certainly a useful skill in this changing landscape of healthcare in the 21st century in the US. So any public health things that we need to be thinking about?
Absolutely. Well, it was great to hear about it from sort of this clinical perspective, that I think as public health, from this public health chair that I sit in, we like to think like long before the patient was arriving at even the work site to start work for that day, like what factors are at play for shaping, the world of that patient. So one thing that immediately leaps out to me is this impact of heat. And we know with a changing climate and looking to the future.
Can I pause you for just a second? So we're gonna get to that public health side, and what's up now is this exact question. Like, let's dive more into that heat. And Dr. Grinke is an amazing emergency physician, so he went above and beyond. But the truth is that exact scenario has happened a lot of times where that creatinine has never been noticed in the emergency room. So let's say we've addressed this individual's arm and then they come back to their primary care doctor. On the primary care side, if there's any takeaway that I want you guys to remember from tonight, it's to think about the things that affect a patient outside of the exam room, which Rachel is about to go in as well. So if we ask him some additional history there, maybe he's back in that primary care office, what happened that day? What happened? Why did you fall? So it was really hot outside there. He reports that he works frequently in the hot weather. He's a construction worker. He doesn't get a chance to take water breaks when he wants to. He's scared to ask for them because he actually is concerned that he may be fired. And he's an undocumented immigrant in the United States, so he doesn't have the protections that other outdoor workers may have. So he's scared he's gonna lose his job. So in this case, if I were this person's primary care doctor, I have to think about this when I'm caring for him. I have to think about that broader context. And this is kind of the image that I hope gets seared into everyone's brain from tonight, is that so much of medicine is focused on caring for the patient right in front of us. We get really good at that, and we train doctors really well at addressing disease once it's happened in a hospital context. But that's just the tiny tip of illness, and it doesn't even begin to approach wellness. And so there's so much of medicine that involves the patient in the rest of their lives outside of that exam room, where they spend hopefully 99% of their time. So we need to think about these other layers of wellness and of care provision. And a lot of that does come from the primary care side. Because you know what, we need doctors who are really good at taking care of the patient right in front of them in an acute care setting. We need that. But we also need the rest of the picture too. And so we want to think about this individual's family context, the broader community context. And I'd like to argue today that we need to think about the forces that are shaping the planet and how they affect wellness too. So part of what I'd like to pose for this case is, if this individual truly is showing heat illness, if we're seeing that, if we're seeing kidney disease from manifest by this elevated creatinine, if this is from heat illness, that's entirely preventable. And that's something that we really need to think about, how we empower this patient to protect his own health. There is actually a new and emerging type of kidney disease called heat-related nephropathy from heat exposure itself, just from being too hot. And it's most common in individuals who work outside. And so the ways that we reduce, we want to think about hydration. How can we empower him in this context? And that's why I'm going to need to call on my public health and legal colleagues as well, because it's hard to empower someone who isn't afforded the same rights under the law. All right, continue with the climate and public health.
Well, I mean, this all just really builds on each other. And I love that infographic that Dr. Phillips showed in that bottom quarter. Sort of, it's more than just this patient in front of you. Why are they here? And, heat is deadly. This patient was really lucky that, that heat can kill people when they are working outside. And I don't know if y'all saw the news from earlier this year in the Pacific Northwest. We had farm workers and outdoor laborers dying in the Pacific Northwest because they were exposed to temperatures that, were way out of the norm for them. And we know in the public health sense that heat disproportionately impacts communities of color. These are folks who are more likely to take jobs that involve physical labor. They're also more likely to take jobs that are more physically dangerous. So, I think I was pulling some statistics. Men make up 80% of the construction workforce, and in the United States, many of those workers are members of the immigrant community. So I also really like the point that Becca flagged earlier about heat protections and OSHA compliance, like that. We have laws about, if you're an outdoor laborer, you should have these protections afforded to you, and have mandatory breaks, and have access to clean bathrooms. And if it's too hot, there should be protections afforded to you. But with an undocumented status, people are really afraid to take those steps. I was reading a paper earlier today about Florida farm workers and cases of 40,000 different cases of heat exposure, and they were documenting that these folks were unable to use heat prevention strategies, water, rest in the shade, changing their work hours. This income is essential, and they can't feel like they can step up to their employers because of their status. So I think I could add more, but I want to continue the conversation down the line. Yeah.
I think that's great. And just to add some maybe personal context here, one of the projects I'm working on, research that's partially funded through our climate incubator, is trying to understand how climate figures into decisions to migrate from Central and South America, and then the persistence of climate-related vulnerabilities upon relocation in the United States. And we've just completed our pilot. So we're aiming to enroll about 50 people, and we only enrolled one male for the whole project. And I think that speaks to some of the challenges getting leave from work to even come to a healthcare setting. This enrollment was done through a patient-centered medical home for undocumented immigrants, and then also fears of deportation and interface with healthcare. So I'd love to turn it over to our legal colleague.
Right. So before I start, let me give a disclaimer that nothing I'm saying tonight is legal advice to you. Nuance and specific facts in real life situations matter a lot. So if you have a situation like this, consult an attorney about your patient if you need to. And I'm an environmental attorney, not an employment attorney. But when we're talking about dangers in the workplace, like heat, we're talking about occupational safety and health, which is governed in the US by a federal law called the Occupational Safety and Health Act, which is administered by the Occupational Safety and Health Administration, often pronounced OSHA. And OSHA regulations require that employers provide a workplace that is as free of hazards as they can make it. And where there are hazards, they have to provide personal protective equipment to employees. In the era of COVID, that's like masks and hand sanitizer and things like that. OSHA doesn't require breaks, though. There's some guidelines that have been set about preventing heat exhaustion and heat illness to employees. But OSHA itself doesn't require breaks. The National Fair Labor Standards Act doesn't require breaks, and Georgia law doesn't require breaks. But when you're thinking about laws in the US, the federal laws set floors, and each state can pass their own laws that are more protective, that do more than the federal law. They can't go less than the federal floor. They can go more than the federal floor. So some states, like California and Washington, have passed laws that require break periods and water to be provided for workers working outdoors. But even in those places, like Rachel was saying, sometimes people in unusual heat waves in the Northwest are still dying from heat exhaustion in the field because they weren't getting enough breaks or enough water. If a workplace isn't safe under OSHA, employees can report the workplace to the Occupational Safety and Health Administration, and they can come in and order the workplace to take certain steps or impose fines on them. And OSHA wants employees to do that. OSHA has in their websites and their materials that they're never going to ask an employee about their immigration status. OSHA is concerned with the actions of the employer, not the employee. But think about in the real world, undocumented employees are hesitant to report things like this because sometimes they are fired in retaliation, even though that's illegal. Sometimes they are reported to immigration, which is also illegal. There have been cases where the Department of Labor or OSHA has come in and sued employers for terminating or getting workers deported in response to having OSHA claims filed. So one area there that advocacy of doctors and other scientists and people who are intellectual luminaries in the public sphere can push for stronger laws, can push for state laws that address issues like this, can push for better protections for undocumented workers. The other thing I'd like to say about this one is sometimes you encounter is a very common misconception that undocumented employees can't file for workers' compensation insurance if they're injured on the job. That is not true. Workers' compensation, just like OSHA, is concerned with the actions of the employer. It imposes a duty on the employer to have this coverage. That's just as available to undocumented employees as it is to citizens. There have been a lot of court cases about that. Now, the employer can still terminate them illegally or illegally report them to immigration. But if you have a patient who's worried that they're not going to be able to pay for care that they need, that is an avenue that's available to them. That might be something you want to think about if you have educational materials in your waiting rooms or your exam rooms.
I think that's incredibly helpful. And I think this is an example of something that's actually happening right now after the Pacific Northwest case. Healthcare professionals are saying this is the result of not having laws that protect health and that are not protective actually in this case of life. And it's played out in this area. We may actually start to see some change in laws. And it's also played out in an area close to pediatrics with high school athletes. So there was evidence that showed that states that have stronger, more stringent guidelines about how hot is too hot to have practice, how hot is too hot to have your full gear on at practice without a certain number of breaks, had more death in high school athletes. And so laws started to change. This is where we can think again, yes, we always need to take care of the patient right in front of us. And it doesn't do any good if we send them back out into a world that's not going to support their health. And we have this incredible privilege of being in a space with strangers that we may get to know over time, but they start as strangers. We see things that other folks don't see by virtue of that interaction with people from all walks of life. And I think it's part of our duty to elevate those voices and the harms that are facing our patient. Anything? Yeah, go ahead.
I just wanted to add, we've been talking a lot about the migration of patients and undocumented immigrants and certain different stressors that cause, people to take this tremendous step to uproot themselves from their home village or city and country, and to go on this treacherous journey to try to find a better life. And I want to tell you that we see this. I mean, I've seen this in ED multiple times in the past few months. I had a teenager who a couple weeks ago, a teenager from Honduras who was in America alone. He had other family members in other parts of the country who were also undocumented, but he was here in Atlanta working as a laborer, and he came to the ED for different reasons. But this is something that we actually really do see the results of. We see this in our hospitals more, and it's when it's a flashpoint in the news a lot, and we hear a lot about it, but once you actually see that firsthand, it really brings it home.
I have a question for the doctors on the panel. In a situation like this one, where you have a worker with heat exhaustion or another employment-related injury, speaking as a lawyer, it's often very beneficial not to get lawyers involved. Have you ever had a situation where you've reached out to an employer or picked up the phone and said, I just treated one of your employees and it looks like you need to be providing more water or rest breaks?
Really good question. I personally haven't. I wonder if in the primary care field that might be a little bit more common. I think for us in ED, we're more about trying to get the patients the resources, but also trying to, unfortunately, we need to keep the patients moving through the ED. So we never try to send people home or somewhere without the proper support, or at least helping them get that support. But I think that might be something that maybe Dr. Phillips learned.
Well, I would say, given that many of our patients aren't employed, I've written plenty of letters about water bottles and, plenty of letters of support for high school athletes to have plenty of breaks for all sorts of reasons. I mean, that, if the employer of a child is school, right? And so oftentimes we're advocating at that level, trying to make sure that the child gets not only maybe a water bottle at school, but breaks to go to the restroom, or in certain situations that I've certainly as a nephrologist, so I'm a nephrologist for those that didn't know that, and have kids who are prone to dehydration for one reason or another, who need to have access to not only the water to come in, but the ability to get up and let it get out. So that's where I think I've probably hit that realm.
Yeah, and I think we have to be careful for HIPAA reasons. We have a little leeway as pediatricians working in school to do it, but we really need to make sure that for the same reasons we talked about, that the patient would be okay if we were to reach out to the employer, especially if it's a situation where they could be identified. I was looking into Georgia child labor laws recently because I did have a child who was working outdoors. I think he was 16 or 17, and there ceases to be a limit of hours you can work around that 17-year-old mark in Georgia. So I kind of went the route, rather than calling his employer, I talked to him and his mom about how really important this was, because his creatinine ended up being okay. We did check it because his blood pressure was really elevated, and I kind of had a conversation with him, trying to empower him. Look, this is really important. You are a young individual here. We need to make sure we protect your kidneys, and we need to make sure that you always have access to water, that you can take breaks in the shoot, that we're able to prevent this from actually interfering with his schoolwork was something that we talked about a lot too. For the most part, it's more just talking to schools and coaches, and I have no trouble talking to coaches. We have lots of good handouts that we've created to help work with coaches as well.
Yeah. Well, maybe one other point I wanted to bring up is, I know we talked about, OSHA and sort of these protections that are afforded to workers, but I know that from public health standpoint, we see in the data that a lot of folks are avoiding coming into healthcare centers because they're really terrified. It's pure terror for their undocumented status to come in and talk with providers. So as providers, like, how do you have that conversation, or what reassurances do you give patients who do actually make it in the door around this really hard conversation?
It's a really good question, and there's not an easy answer to it, unfortunately. I'll say that we will never call any authority on a patient that may or may not be undocumented, and we'll do our best to protect that patient. There are certain circumstances that we can't avoid. For example, with this patient I had mentioned, this patient had some mental health concerns at the time, and so our primary goal was to make sure that those were taken care of. It's hard to, in a child, somebody under 18, it's hard to avoid having some kind of authority involved in that, in these types of situations, because we need to ensure we can't just discharge a minor back out to a work environment that so it gets a little bit tricky, and I think that we do the best that we can, and I don't know what happened to that particular patient, but again, and from ED, it's a little bit different than when you're dealing with patients that you might know the family, in clinic that you see, and I think that those are different situations. So maybe our colleagues could comment on that a little more.
I guess I put a plug again for this multidisciplinary event. The biggest factor in building trust, I think, with my families who have either one or both parents are undocumented is our interpreters, who are amazing. And we're lucky enough that we have in-person interpretation for Spanish every day. And they really help us build that trust and will help provide parts of the story that maybe someone is scared to tell me because I don't speak Spanish. I leave the room and come back and there's a whole nother story waiting for me sometimes with our absolutely incredible interpreting services. And we try to build that trust over time. In primary care, we can do that. So ask questions, but provide reassurance. I have written letters documenting that a child is medically complex and has special healthcare needs to try and avoid having parents be deported. We have had situations where parents of our children and it's really heartbreaking. So there's not an easy answer there. I think having that community building over time. Maybe we should try and that was a great discussion. We'll go pretty quickly through this case and we'll try and almost a more rapid fire perspective from all of us. And this is a very, very common case. You're in the Hughes Spalding Primary Care Clinic when patient X presents with a cough and wheezing. He's a 9-year-old boy with a history of asthma who reports difficulty breathing and shortness of breath that started when he was playing outside. So flashback to continuity clinic now.
Yeah.
Right? Hughes Spalding.
Or last night, honestly.
Or last night, yeah.
At Hughes Spalding just downstairs.
Yeah, so asthma prevalence is something that affects around 1 in 10 children in the US. So kind of common.
Yeah.
What would you do?
Yeah, and I saw this patient multiple times last night, multiple patients with this exact presentation. This is an incredibly common thing. Respiratory illness is the most common pediatric illness we see in the emergency department. So what would I do? Well, there's, again, in the emergency department, as I mentioned before, we call it ABCs, airway, breathing, circulation. So it sounds like this child is having some difficulties with not necessarily the airway, but the breathing. So we want to address that. This looks and smells like asthma, especially if we have a history that this child, if we're able to look up in the chart that this child has a history of asthma, we'll be able to kind of hone in on our treatment pretty quickly. So we'll give different medicines that basically try to open up those airways that an asthma kind of collapse down or kind of tighten a little bit. So we give medicines to loosen the muscles to allow that air to get through down to the deepest part of the lungs more easily. We do that multiple different ways depending on how severe we think the patient is at any given time. And
And
this is,
can you say, truthfully, that probably would have all happened before you even ever saw the patient because of our asthma pathway. So
Yeah.
how does that work?
yeah, so it's really cool. When these patients come in, they are assessed by a triage nurse who will get the basic information about what's going on and be able to assess the patient. And again, if it looks and smells like asthma, they will go ahead and just start the treatment. So they have very specific protocols in the computer that, based on a scoring system that they do called, for us, it's the CRS score. It tells the nurse or the respiratory therapist exactly which medication to give and how much of it, based on the patient's, usually the weight of the patient. And so, yeah, often by the time that the doctor gets in to see the patient, unless it's a patient who's really, really sick and they bring us in right away, often these patients have already started their treatment. So they're already on a nebulizer treatment, they've already gotten their steroids. And so then it makes our job a little bit easier. And again, it's that team effort. Really, everybody has their role. It takes a village to really make this work well for the patients. And so, yeah, that's how the pathway works.
I'm hearing nursing and respiratory therapy and pharmacy involved. We need the information technology people to build these order sets in our electronic records, so we can really see all the different rules.
Perfect. And we won't listen to the sound of wheezing, but there are lots of good clips out there for that. So what else do I want to ask this person? They're in their primary care clinic, so we take care of them. We want to really know, what are his triggers? How did this happen? So it sounds like he has sensitivity to pollen, which can be a trigger for asthma. He has a history of wheezing. They live near a major highway. There's lots of exhaust around that highway. They have heavy traffic in the afternoon, and this really started when he was just playing outside in his own neighborhood on a warm summer day. And pollen count is something I really didn't know what it meant until I got to help, but it's the grains of pollen per cubic meter over a 24-hour period. So 8,918. This is from last year, one of our high pollen days, is why we feel like we're swimming in pollen in Georgia. For those of you first years who haven't gotten a chance to see that yet, you'll get to see it this spring, but the whole world turns this kind of yellow green color.
Your slide, yeah.
And how do we advise him? And this patient, as David mentioned, he sees this patient all the time. It's something that I could care for this child in my sleep as a resident, really, quite truly. We knew exactly what to do when this child is right in front of you in the exam room. This is partly like the frustration that led me to want to engage with this more as a career, is it doesn't do a bit of good if we make this child better in the exam room, and it makes them better for the moment. But if we send them back out into the world without addressing those things that make them sick to start with. So how do we prevent this from happening is the big question. And sometimes that takes more than the limits of what we can do alone as physicians. And that's why we need partnership with an interdisciplinary team too. So in the clinic, though, there are some things I can do. One of the things that I'm trying to do is every child who comes in with asthma gets an asthma action plan. It's kind of reactive though. It talks about what triggers are, but it really says, if you start having symptoms, then do this. One of the things that's not reflected as a trigger right now in our asthma action plan is air pollution. And yet we know that air pollution actually, more than a recent UNICEF report for the United Nations, more than 90% of the world's children live in areas where they are exposed to unhealthy levels of air pollution. So that's not good news. Air pollution is a major determinant of child health. And when we look at how air pollution affects the lungs, it turns out that children's lungs are one of the last organ systems actually to stop growing, the brain being later than the lungs, but lungs are still growing after children are born. So when a child is exposed to pollution, it limits the actual growth of their lungs and how much air they can hold. It limits the amount of air that they can breathe out, and something that we as physicians would call pulmonary function tests that actually stunts their development. It really matters. So I want to be able to empower my patients about, if possible, how to avoid that pollution, especially if they already have asthma. Pollution tends to be worse in the afternoon. It tends to kind of build up in on a smog-like way in a hyper-local area. So if I were talking to this patient in clinic, I would say, to get your exercise, if you can, try and be out in the morning. You really need to look at your air quality index, and now all of our phones, our weather apps pretty much have that air quality index. I'll look at their smartphone with them, and I work in a clinic that serves children who are almost exclusively low income or on Medicaid insurance or who do not have insurance, and most families have smartphones. Everyone just has a smartphone. So I would look at their smartphone and show them how to access that air quality index and say, this is when we need to be careful for your child and your children and your family. But like anything, I do not want to put a disproportionate burden on a family that's not responsible for that air pollution being there in the first place. So that's why I advocate outside of the clinic for changes as well. And that's where I'll turn it over to Rachel.
Yeah, I'll try to keep this brief as well. But we know that marginalized communities and communities that have been historically underfunded, generally communities of color, they're bearing a disproportionate burden of air pollution, both from these chemical backgrounds, whether it's exhaust tailpipes or industry, but also from pollen. And I wanted to quickly touch on our last example. We talked about heat. There's this sort of really interesting interplay when you have hotter days in places like big urban centers like Atlanta, where the exhaust from tailpipes on cars combines with the heat in the air to produce ozone. So you might have a day where a kid in the afternoon, when it's really hot and they're outside, they're close to a freeway where there's a lot of exhaust coming out of car tailpipes. It's a hot day, so there's a lot of ozone around. And then with pollen, we're actually seeing now this is more of the climate change hat, the public health hat, but we're seeing this change in plant pathology, which is so wild. We're seeing longer pollen seasons that are more intense. So you're getting those crazy days where you have all of these different plants that are producing way more pollen. And it's just this perfect storm of respiratory complications, crashing down on a child that, has a developing airway. I know we have some data up here. I don't know if we want to really go into this right now, but very, very briefly, there is a history of redlining in this country, and maybe my legal colleague could probably say a lot more about this than I could, but it's a history of, racism and how housing policy was developed. But it's basically resulted in communities across the nation sort of having these really polarized ways that communities are built, where you have a lot of affluent, typically white communities living together in a place, and you often have communities of color that are underfunded and closer to industry, closer to highways and interstates and all these polluting sources. And so what this graph is showing, this is a graph that Becca pulled for me, but basically you have different types of these areas that were classified by a housing authority on are we going to is this an area where typically white affluent families live, or is this an area where typically communities of color, immigrant communities are living? And these are this risk grade, this HOLC risk grade is basically saying the A's were these white, typically affluent communities, whereas these D's are communities of color, less socioeconomic wealth there. And what you're seeing on this y-axis is the age-adjusted rates of emergency department due to asthma per 100,000 patients. So what you're seeing is the white communities are having less, or in these affluent communities are having less folks go to the ER with asthma. Asthma admissions. When you move further to the right, you're seeing these communities where historically there has been this example of redlining. There's just a legacy of pollution and infrastructure that still has impacts on health today. This is still, we still see the skeletons of these living in cities across the country. So, and all this on top is just statistics saying, yes, in fact, this community is very, very different. There is a statistically increased risk of asthma a statistically increased risk of asthma admission among these communities that have been historically redlined. So that's as brief as I'm going to keep it, but yeah.
Yeah, and I think that the idea there too in medicine, we've really been talking a lot about structural racism and structural determinants of health, and how this is a federal policy in the 1930s that disinvested in predominantly communities of color. It was because they were communities of color. That is structural racism in practice, and it has lasting health consequences. And instead of having investment come to those areas, there were less desirable infrastructure projects that were cited, like And this is that we're still seeing the legacies of these racist policies play out in the health of children. And this is something that I think is really important for you all to learn and for med students to learn. Part of what we want to do is dismantle that legacy, and how can we do that if we don't know about it? There are far too many times where I've seen this patient, our patient, come to the emergency room or the clinic. People start talking about compliance. This patient may be non-compliant, but we know actually that the rates of asthma in Black children in the US are twice as high as in their non-Hispanic white counterparts. That's not non-compliance, right? And we need to teach it as for what it is and understand this. I'll turn it over to our
Sure, I'll try and keep it super brief. In the legal field, the term that we use to talk about this idea is environmental justice, which sort of evolved from a term called environmental racism. And it's the recognition that the harms from pollution and polluting industries disproportionately fall on low income and non-white people. Some of that is intentional. These communities that were redlined, where all of the sort of minority population was concentrated together, presented really attractive areas to site industrial facilities or to site highways. Highways, when they were being built, were built through Black communities, not white communities. And so now you wind up with a situation where you have communities living right next to a highway and being exposed to all this air pollution. Unfortunately, environmental justice is, there's not a law saying that that's illegal, that you must not, that you can't have these impacts fall on non-white people worse than they're falling on white people. Starting in 1998 in the Clinton administration, there's been an executive order that orders government agencies to consider the impacts of environmental justice when they're spending government money. But an executive order is not a law. It's still not illegal to build a power plant that's going to disproportionately impact the community. In this specific situation, the law that governs emissions from cars and vehicles is called the Clean Air Act. The Clean Air Act sets limits on what mobile sources, by which we mean cars and trucks, can emit into the air, but those limits are set per vehicle. So if you're living on a country road and somewhere out in the rural part of the country with 5 cars a day, you're getting a completely different dose than someone living right next to the downtown connector here in Atlanta. And that's even assuming that companies abide by those limits. You may have heard of the Volkswagen scandal 3 years ago, where a car manufacturer installed software that would make the engine run differently while it was being emissions tested so that it could pass emissions tests, when really it was being much more polluting than was allowed. I'll try and end on a high note though, which is that advocacy for stricter standards can have great effect. Back in the day, we used to see a lot of high levels of blood lead in children because of the lead in gasoline. Lead in gasoline when burned was emitted into the air. And after lead was banned from use in gasoline, there was a really dramatic drop in lead levels in children's blood. So some of those standards can really help. And we knew about the lead in blood because of the work of doctors and scientists. So there's a real opportunity there for you to advocate for change, for stricter laws, and for better standards to protect children.
I guess we have, I'm gonna flip through this and go to the last slide here. I think a lot of what we've talked about tonight is how, as physicians and future physicians, hopefully we can use our healthcare lens to advocate for a better world while we're taking care of the patient right in front of us. And there are sometimes where what the world needs and what our patients need align, and it's a convergence of opportunities. And I think that's where our voice is needed in the broader space. So even here, as we're talking about pollution, tonight's about climate change. Drivers of pollution and drivers of climate change are the same thing. And advocacy right now by health professionals all over the US and all over the world will be featured heavily in COP26, the Conference of Parties that's happening next week, as the world comes together to decide, are we going to address climate change and how well are we going to do it? The healthcare lens to that has been key in making sure that we are able to advocate for a livable future for children and a healthier one, so that immediately reducing things like tailpipe emissions and industrial pollution has immediate benefits for health, for child health, for the amount of lungs a kid's air can, for the amount of air a kid's lungs can hold. And that's where we as healthcare providers, whether if we're looking at the emergency room, primary care, public health, or the legal side, can come together and raise our voices for a healthier and more equitable society.
Thank you all for all of your insights and your valuable contribution to this discussion. Thank you to the audience. We probably have time for a couple of questions. Does anybody have a question that they'd like to address to the panel? Yes.
I have a question for Ms. Rachel Usher. So, what are your thoughts on medical waste? Do you feel like a lot of equipment trying to be exposed a lot of medical waste?
Yeah, I'll start off and say a resounding yes. Medical waste is huge, and I actually might have Becca weigh in on this too, because I know there was some presentations recently from Emory Healthcare on this very topic. But you know, I also my dad is a clinician as well, and he sees it even just in his career as a physician in the OR, seeing how things have really changed from reusable things to these single-use, disposable, and increasing reliance on, you know, plastics across, you know, so many different aspects of medicine. I think from the climate change perspective, and this is really drawing on a lot of the work from Drawdown Georgia and Georgia Climate Project, you know, it's recycling and thinking about how sort of the full waste stream is really integral for thinking about the total emissions of something, like an item being produced. And how it gets disposed of is a really important part of the process. And I'm not an expert on where medical waste goes, but I think broadly speaking, similar to so many other streams of waste in our society, we really aren't considering, you know, when it goes straight into landfill, you know, what that process looks like in generating even more emissions that result in all these other health consequences. So I think it's a really important space for healthcare providers to really lean in and provide some leadership on showing why waste is a really important, you know, health issue down the line. But I'll let Becca maybe say some more on Emory Healthcare and what they're thinking about.
Yeah, I love that question. I think it's the right question, and it's a question that students have been asking too. So I'm really proud of some of our students recently have done a waste audit in one of our neuro ICUs at Emory Hospital, where they collected all the waste and wore their hazmat suits and kind of looked at what was being thrown away, and was it biohazardous waste that has to be incinerated that creates a lot more emissions, or were the bins getting mixed up, or people throwing things in the wrong containers, like our sharps container for needles. There's a lot of cause for hospitals to be held more accountable for the Hippocratic Oath, first do no harm, in how we deliver care. And I think this is something that we know actually has to change. We kind of can't keep doing the business the way we've always done it. So looking at a life cycle approach for what goes into a product as it's created and what happens to it when you're done with it is something that hopefully hospitals will start to do, both from the trash perspective, like medical waste, and also from an emissions and from an accountability perspective. There's a huge environmental justice component as well, because where does waste go? It goes through those trucks carrying our waste go through the communities that we're trying to serve. And ironically, COVID has had both good and bad effects on medical waste. I think it's really showed the vulnerability of our supply chains, so that some places have fallen back on more reusable items because they couldn't get the disposable ones. And it's also created a lot more of this. So it's kind of gone both ways, but it has at least gotten people looking at it more closely.
I'd say 2 years ago, I don't know that I saw masks on the belt line or, you know, tossed aside. And now every day I could count hundreds of them. So we all have a part to play. Not to defend medicine too much, but, you know, it's community waste, it's public health waste, it's wastefulness, period. So
from the legal side, most medical waste is considered hazardous waste. And so it's subject to a whole structure of regulations and rules and how it has to be handled and disposed of that I'm not an expert on. So there's not much I can say about that, except that I think there's probably a really important role for doctors to play in narrowing definitions of what has to be considered hazardous versus what can be recycled or reused.
Well, thanks everyone for coming out on a rainy autumn evening. I hope you learned something, and thank you again for our panelists.
Right.